Well, the title of my talk today is called Pay for Performance, the Catalyst for Fracking the Financial Processes. And the reason I've used this title is very deliberate. Anyone that knows oil and gas will understand fracking. They'll understand the positive aspects and also the unintended consequences of it. That's why I've used it, and we'll talk about it a little bit later. My role is as Chief Financial Officer for Vancouver Coastal and VP of Fund. That's what I call myself. I do fun stuff. I do systems development and performance. So I work mainly on trying to find interesting things to do and make them real. Just a little bit of history. We started in 2007. In 2006, we had lots of press telling us how bad we were. People were lining up in an emergency. We were losing a lot of money. We were losing $50 million a year, which is quite significant. People lost their jobs because of that. So we were the first ones out the gate out of necessity. And we knew that we needed to learn quickly. Because in a global funding world, the more efficient you get, the worse it is for you. So just a little bit of background. In 2009, this was expanded beyond the borders of Vancouver Coastal to something which we called the Low Mainland Innovation and Integration Fund. And that covered basically ourselves and Fraser Health, which is in our area. And the amazing thing was that there was $50 million set aside. Not a lot of money in a $15 billion provincial budget, right? But we couldn't spend it all. And that's one thing a lot of people tell you about pay for performance. You'll overrun every time and you'll get into trouble. That doesn't happen because there's accountability. And in 2010, the Health Services Purchase Organization was formed. And this was a provincial body which actually sat outside all our health authorities and was basically the mechanism to provide funding based on agreed accountability contracts. We also didn't spend all our money on that one. 2011, that was increased to 130 million. We spent about 100. 2012, the budget's come down a little bit. I think they realized we're not good at spending all the money, even if it's on the table. Split into two things. One is Accelerated Integrated Primary Care Fund, which is 50 million, and the hospital-based funds, which relate to activity-based funding in our hospitals. For us, we thought about it a lot, and pay for performance is a disruptive innovation because we're not playing around the edges. This has fundamentally changed the way that we think about healthcare in British Columbia. And I know it's really disruptive because I can hear the pain, the anxiety, the stress, the wish to go back to the old ways of my colleagues. It fundamentally changes the rule of what block funding does, which are backroom deals done with individual health entities. And eventually you come up with some quiet deals. Pay for performance is transparent. And it changes the decision process. You can't just decide, okay, well, to balance your budget, you know what I'm going to do? I'm just going to cut service. You can't do that because you'll lose the related funding related to that. It's transparent and accountable, and it's hard. And the most important thing that I've learned from this, it's not about the money. It's never about the money. It's about creating confidence for the healthcare providers to make decisions at the point of care that are the right decisions and know that there will be funding to actually support their right decisions. That's probably, on that slide, probably the most important thing to take away. What it also means for people like me who sits with my finance hat is that budget and financial reporting processes need to become very, very nimble. The ability to just sit and annually provide a budget, break it into little chunks, have these little fights and wars and who needs what, cost pressures increases, those days are over. We don't talk about that anymore. We only talk about activity, we talk about acuity, we talk about what our strategy is around efficiency and effectiveness. We do not talk about anything else but those things. So it's funding and the budgets are a byproduct of that. And finally, collecting baselines and getting real good information is hard. We've been spoilt in Canada. We've been able to get away with not collecting and managing in real time, not being able to actually really understand our numbers, and have these anecdotal discussions on why we didn't make our budget this month or this week. When I joined in 2008, we did not even know how many people worked for us. We got our results 6 weeks after month end, And my very first month, we lost $25 million. I thought, wow, this is going to be a short ride. Well, I thought, wow, I can't live like this. You know, today, I can turn on my computer, I can put it on my phone, and it'll tell me my flow into ED. It'll tell me how many discharges I've got. It'll tell me all the major things. It'll tell me about how my emergency departments are working and how the flow is going through the system. Very important, because if you know that, you can actually predict basically anything. You know, so I've talked a bit about this. I'm not going to spend a bit. Probably the only thing that I'd like to add to this slide is that we have Vancouver Coastal is a $3 billion organization broken basically into 3 geographical regions, which we call communities of care. And probably this is the one thing that I feel very proud of working in the Canadian system, because we do have these linkages between basically our primary care physicians, our home support, our residential care, and our acute systems. We already have those linkages in place. So it's much easier, and context is very important to be able to work in this environment. And, you know, we worked out that close to 26% of our current budget is funded through activity-based funding in one way or another. You know, so it's quite a high percentage, but to Meredith's point, it is a mixed model, and probably will always stay that way at some level. It's getting that balance right. You know, and I must emphasize that pay for performance needs a system view. You know, I hear a lot of people saying, well, we should only spend our money in outside the hospital. We should not incent anything inside the hospital. It's fundamentally wrong. We have to move people effectively and efficiently through the system and put them in their care setting that are as appropriate as possible. We have to deal with all those issues. That's why we have to deal with it as a system, and that's why we have to have financial performance and systems to actually support this. You know, so you'll hear I'm not talking about money. I'm talking about doing the right thing for the patient and allowing the incentives to actually support that. You know, so one thing I learned I was at the Cahspr conference, and it struck me that we all use the same words and they mean different things. Pay for performance, I just want to be quite clear what it is for us, and because it is quite different everywhere else, and I've read a bit about it. We are organized into communities of care, so that's one aspect. All money goes to the communities of care. That's very important. No money goes to me. I don't earn a single cent if we do better or worse. That's how it works. This is all about making the best decision and making sure that the providers have choice in terms of being able to find ways to actually deal with it. But nobody gets any money. So this is probably a truly Canadian thing, that we all work for the better good, but we're providing a way to actually do the right things. Pay for performance is not an improvement strategy in itself. It must be invested in improvement, and that is the key. You know, and that's why it works at Vancouver, because people know that if they do their part of the contract to deliver it, the money will flow. That they will be able to invest in the areas that are important to keep this flow and this thing working. And the hospitals have choice. They're free to invest as they see fit. And it's very interesting as we go through it how each area has different ways of spending their money and which was the most effective in learning from that. What it is not, it's not a way to make people work faster. It's a way of making them pay attention, you know, and it truly is. Money is not the incentive. I heard Dan Florizen from Saskatchewan yesterday talk about it's not about money and it's not the incentive. He's right. It's not. Improvement is the incentive, and the real issue, and I thought about it really hard, is that finance people like myself are the obstacle to making this happen. And what pay for performance does is give confidence that the contract will be met, that we will do what we say, that the money will flow, that the commitments that they put out will be dealt with. And you know, if it's not a reward, what is it? It's really a shared risk strategy. It's really saying, okay, you sign, and those accountability documents are real. You sign on the line that you're going to deliver this, and we're going to give you that. You don't deliver this, you don't get that, right? Simple. So you take some risk, you know. So if you say you're going to do something, you better deliver it. So it changes the whole accountability discussion that we have with our staff and with our physicians and with people across our continuum of care. I had to put this one in. What it's definitely not. Pay for performance. If I save your kidneys, I bill you once. For the consult. If your kidneys tank, I bill you 3 times a week for the rest of your life. That's what it's definitely not. I had to add a bit of humor to this presentation. Pay for performance. Learning from the UK and the US. I pulled out most of the slides on this because I just wanted to keep it quite short. But the reality is that there are great lessons learned. One lesson learned from the UK is don't incent what's ever already good, because all you'll do is be chucking good money after bad. So you need to be quite careful, and you've also got to be quite careful about the unintended consequences. We've been quite fortunate in British Columbia to have a health service purchase organization be very careful with those leaders, not to over-incentivize activity in the acute system, because that's our biggest, most expensive area, but to really incent same-day care and really incent keeping people out of the hospitals. It's a really, really important process. So getting that tweaking right is very important, and I don't think you ever get it right. You just keep tweaking until you actually get it there. We have 4 programs in fact, 5. Emergency department pay for performance. That's really making sure that people get through in the right amount of time and in laid out times, depending on their condition. Activity-based funding, which is really about paying the hospitals based on a resource intensity weighting basis for the work that they actually do. The coders have become absolutely critical in this element, and the thing we watch out for is upcoding for sure. But what it's done for us is, one of the very first things I did when I got to Vancouver Coastal, we went through a restructuring because we were losing so much money. And one of the things, to my great regret, that we did was we didn't realize the importance of the coders, so we actually let a few go. Really stupid, really. It's I just shudder at the thought. So we brought them all back. So and instead of being okay to have it done in 3 or 4 months or whatever, now it gets done. Every month we know exactly what it is. It's very important to know where you are. Community initiatives. I'm going to talk a little bit about that later. And then procedural care is actually basically bulk buying for high waitlist areas. And the final one, this quip, which is really around, I should have put there quality, because it really is about making sure that what we're doing is that we're doing it for the right reason. This is not about money. So we actually align ourselves to some benchmarking and to show the performance we've got. Jason Sutherland is also doing some work for us to actually look at our pay for performance projects. So we see ourselves as a learning lab for what we're doing. And the results have been quite amazing. We've seen wait times go down from 40 to 25%. These are but I really want to talk a little bit more about the other side of the coin. And I was very pleased to see, Meredith, that you have some of those negative consequences as well, because this is not all about getting paid for doing things, but it's also holding people to account in terms of meeting wait times and wait lists. And it hurt quite a few of the health authorities, not us, but it did. And so there's lots of debate around whether that's good, bad, or different, and how you do that in a publicly funded system, who pays for those losses, etc. But for us, it was quite clear. We were very focused. We knew how many cases we had to do. We had visibility every single day. We made sure that we worked with our physicians to get the wait lists down. It made us better. Okay, and that's why I like positive and negative consequences. Accelerated integrated primary care is really the key to moving and changing the cost structures in our health system. And we just started that. I mean, we first started with emergency pay for performance through the acute system, and now into the community projects. And I'm absolutely amazed by what it's done for us. I'm going to give you an example of one where we in the past we'd keep people in hospital with with what we call alternate level of care status until they're ready to go to a residential care facility. We don't do that anymore. What we do is we actually take people home where they're comfortable and where they can make good decisions. And what we found with this initiative is we had to provide the necessary support at home to make sure that they were safely taken care of. The premise was that these people would eventually go into residential care facilities because they actually met all our wonderful criteria that we set out for these things. What it's done is 92% are staying home because we provided the necessary support at home to live happily in the surroundings that they want to live. You know, this is an amazing story, and we're going to see many more. We only had time to really do one here, but we've got ones on mental health, on frail elderly, and a number of others which I'll be happy to share. But these are the important things. What it's done for us is it's changed our alternate level of care percentage. And that's really important in our hospitals because those are really expensive beds to keep filled with people that shouldn't be there. So that's brought it right down. You know, I know in Canada that alternative level of care sometimes is in the 10 to 20% level. You know, we're aiming to be less than 5, and we're at 10 now, and we want to be lower, and this will help us get there. And so finally, you know, fracking the financial and operational processes. As someone from South Africa, I have to be very careful how I say that. But what it is using pressure to free precious resources from the earth. Pay for performance. And I realized that as I was writing this presentation, is the force to extract the precious resources from the operations. What it does is it blows up the current financial management models. And because the reason it does that is the money has to flow. And if the money can't flow freely, and you have very rigid management structures and management processes, you're in big trouble. So we need to get really agile. So just to show what fracking looks like, this is what it does. This is in natural gas. What it does is it drills down through all those layers, through all the silos in your organization, and it uses a lot of force to blow them all out. In this case, most of the oil goes to the right place, but as you can see, some of it's actually going into the watershed. So when I say fracking, we've got to do it carefully, so we actually capture it without doing some of the damage that can happen from these areas. What I wanted to share with you was what agile processes actually look like. It's around real-time information, and for me, it all came together when I thought, we've got all these forecasting modules. We can forecast. I know exactly how many people are going to be in every one of our hospitals tomorrow morning, because we have the ability to forecast who they are, what they are, and what their complexity is. This is quite amazing. I can now plan. I can now do something proactively. I can plan my staffing. I can plan our discharges. I know how many beds I've got there, and I know that I have to manage this in real time. So this makes us really agile. So what it needs is forecasting and scheduling software that predicts census, volumes, mix, physician and clinical staffing, operating room, and acuity. Because if you've got all that, you know exactly what to do. It's not a surprise every day, and I'm surprised that it's a surprise every day to many hospitals that it's much more predictable than you can ever imagine. And using analytics in real time, that's very important. Our folks, I don't need so many finance folks anymore. They're there actually helping the frontline make decisions in real time. Should I open these beds? Should I flex them? Should I bring these people in on overtime? And they'll be able to say yes because we've got the necessary pay for performance to deal with that. And a lot of it is making sure that we do it in the most effective way. So if you know early, 4 days in advance what you're going to get, you know how many people are going to be there. And I'm just going to leave that for the moment and just move. Just in terms of the good old days and the bad old days in terms of budgeting, it really the good old days, which are really the bad old days. It's a game of chicken. Fixed budgets set in stone. No incentive to improve. Cut service. Wait time's not really important. Do the best that you can. Now, this is now revenue focused. You need to understand all the moving parts in this world. And pay for performance actually helps us do that and helps us become really accountable, because we can't just cut and take the easy way out anymore. So it's really Armour versus fly-by-wire. And that's really what it looks like. That's what my computer is going to look like in 2 years' time. It's going to have every single thing. All our people will have the same dashboard in terms of running this. The key message is that pay for performance works. And it's not at the margins. Accountability is key. We have to blow up the old model. It is a catalyst for an agile financial process. Flexible real-time information analytics are really important. And cash and funding must flow to the places that you promised them. So therefore, you need to design it. Coders are king. They're the rock stars. And Kai-Hai, I think, can play a big role in stepping up and doing some work around creating equivalent resource intensity weightings outside the hospital walls. And lastly, and very importantly, you need an outside funding agency like the HSPO to keep your feet to the fire. That's all I have today. Thank you. Where to from next? Okay. The only thing is we're rolling out Don't Pay for What You Don't Want, which is quite similar to what Meredith was talking about. We will be the first one in Canada not to pay for UTIs, not to pay for MRSA infections, and we'll let you know how that goes. That should be fun. That's it. And I would like to thank David Thompson and Dr. Les Vertesi, the leaders in our health services purchase organization, for guiding us, and Les for stealing some of his slides, and Jason for inviting me, and for his work in evaluating our programs. Thank you very much.